Good morning, everyone. Thank you for joining us today for the Population Health Collaborative bi-monthly webinar series. My name is Karen Hall. I'm the Population Health Improvement Program Manager at the Population Health Collaborative. So today we're going to be hearing from Dale Zuchlewski, the Executive Director of the Homeless Alliance of Western New York. He's going to be presenting about housing and healthcare. So Dale Zuchlewski joined the Homeless Alliance in September of 2010 and was appointed the Executive Director in December of 2010. Previously, he was employed by the City of Buffalo in various positions, including serving on the Buffalo Common Council for 8 years, representing the North District. During his last 10 years in City Hall, Dale managed four HUD-funded housing programs working with 37 nonprofit agencies. Dale has a long history of being active in the community through coaching baseball and softball, as an activist for numerous community organizations and causes including educational issues, waterfront reuse, neighborhood planning, and homeless advocacy. In 2014, Dale and the Homeless Alliance were among the lead organizations of Hands Across Buffalo. Most recently, Dale was appointed by Governor Andrew Cuomo to serve on the New York State Interagency Council on Homelessness. So Dale, thank you very much for presenting this morning on our PHC webinar series. And just as a reminder for folks out there who are listening right now and watching on the webinar, everyone is muted, and if you do have questions, there will be some time allotted at the end where you can input your question into the webinar. Everyone is muted, so we will field those questions to Dale at the end. So on that note, Dale, I will turn it over to you.
Thank you, Karen. Thank you again for the opportunity to present, because we've already seen some progress in collaborating with the healthcare industry through the efforts of the I still call it the P2 Collaborative, I'm sorry. But here at the Homeless Alliance, we're known as the continuum of care for Erie, Niagara, Genesee, Orleans, and Wyoming counties. And there are 400 like continuums throughout the country, and we compete annually for homeless funding. In last year, just in September, we submitted this year's grant for $12.7 million. And this money gets distributed to various homeless service providers, mostly for permanent supportive housing and rapid rehousing, not shelters directly. We also maintain a homeless management information system for those 5 counties and Cattaraugus County. And that system collects client-level data similar to Healthy Links on homeless clients throughout these 6 counties. And we use that to provide data analysis, strategic planning to end homelessness. We use it to provide annual reports to HUD. We provide quarterly performance reports on the agencies that do receive the funding. And again, the funding that we are responsible for bringing into the community is used for permanent supportive housing, which is for people with disabilities, usually mental health or substance abuse or physical disabilities, and long-term homelessness. Rapid rehousing, it is a short-term intervention to help people get back up on their feet with limited case management. The funding goes for coordinated entry. I'll get into that a little bit later, and planning purposes, because we have to try and figure out how to end homelessness and what partners need to be at the table. We use the homeless management information as a tool, and it really collects a lot of demographic characteristics on persons experiencing homeless or at risk. All projects funded through our Continuum of Care grant or the HUD-funded Emergency Solutions grant that gets distributed to the City of Buffalo, the County of Erie, and the City of Niagara Falls. And then supportive services for veterans and families also has to input that into the system. And the coordinated entry system actually triages homeless clients and prioritizes them for housing services based upon the vulnerability to be victimized. Similar to coming into an emergency room, HUD wants those with the highest needs to be served first. Like I said, same thing as the emergency room. Somebody with a heart attack is going to go up to the head of line ahead of somebody that may have broken their toe or something like that. The benefits of the HMIS system are, one, it is HIPAA compliant. It is a very secure system. It requires informed client consent to be entered into the system. The client does not have to agree to have their information entered into the system in order to be served, similar to a hospital. But it provides for data sharing amongst the community-based agencies to better serve those experiencing homelessness. It can helps us determine the length of homelessness, where they've been, how long they've been in shelters, when they've been housed, how long it takes to house people. And it's really a valuable tool for evaluating the provision of services. But it also provides quick access to the housing assessment tools and the ability to triage clients into the coordinated entry system. We're trying to do everything electronically. Again, when I go to the doctor, if they have to refer me, they refer me over to a specialist. We can do the same thing through the HMIS system and coordinated entry. And it provides for by name lists for people that are referred to rapid housing and permanent supportive housing. And committees get together and actually basically they refer people out to different housing providers in order to get them housed. We're also able to do customized reports. We provide those for people that write grants and things like that, and we provide annual reports to the community also. And it also helps us identify community partners who are currently working with the client. You can go into the system and know that someone's a client at like the Mad Urban Hope Center, so you don't necessarily have to collect all the information again. You may be able to call over to the case managers and collaborate and see what they've done with the client and why they're showing up here. Because we all know clients always say, "Oh, I've never had services before." So it gives a further tool for that collaboration. This is a quick definition of homelessness. I won't go into all the details, but for HUD purposes and for our funding purposes, you have to be literally homeless. Many people think that those sleeping on couches or living with friends or family are homeless. While they are unstably housed, HUD does not consider them to be technically homeless. I just run through some quick statistics. We're about to start our 2017 annual report, but we've seen homelessness increase in general, especially in Erie County. It increased by 500 last year. We're projecting an increase again this year. We don't have as great a data on Genesee, Orleans, and Wyoming counties because we're newly merged with them, but it dropped slightly in Niagara County. And all these stats are generated by the Homeless Management Information System. But some of the reasons that people become homeless are lack of loss of a job or income, including public benefits, household disputes. Usually, if you're living with friends or family, you kind of wear out your welcome after a while. Domestic violence is a big reason. But these are just some of the things that the Homeless Management Information System can do. We look at various age groups. You can see two peaks at 25 to 34. The more resources are being driven into that 18 to 24-year age group to try and stop that trend of it increasing. And you also see that 45 to 54-year-old age population. I was at a conference back in July, and Dr. Ben Carson, the Secretary of HUD, was there, and he had a couple of very telling quotes, and this is one of them. A man will not beat an addiction from the gutter. He will not get psychiatric help from underneath the bridge, and he will not find a steady job without a steady address. And it's, in one sentence, he sums up the need to connect people with housing for their own benefit. And one thing that I've been telling people for a while is some of the most brilliant social scientists have been studying data from the Homeless Management Information System and other data systems worldwide, interviewing clients, doing long-term studies, and they've come to the conclusion that the way to end homelessness is to give someone a home. It's really not rocket science, but it's not as easy as it sounds either. But if you're homeless, the first thing you need is a roof over your head. And there is a model that is now a best practice that started in the 90s in New York City and almost simultaneously in Seattle, where there was an old housing ready model where people and agencies thought that a client had to go through a certain number of steps in order to be ready for housing, because if you had a mental illness or if you had an addiction or you needed to be placed in a shelter, and then you go to transitional housing, and you had to be clean and sober in order for you to be ready to finally go through all these steps in order to be housed. And a lot of times many people would fail. I don't know if you've ever known anybody that's tried to give up cigarettes. Rarely does somebody give up cigarettes at the first time. You stop, you start, you stop, you start, and it's just not that easy. And it's the same thing with any other addiction. I ask people if they could live without coffee in the morning. You drive by Tim Hortons in the morning without stopping for that cup of coffee. And coffee's not an addiction, but I see people clutching their coffee cups. People on the webinar now probably just clutching it. You can do anything you want, but don't take away my Tim Hortons. And it's just that kind of thinking that needed to stop. And in homeless housing has become part of the healthcare treatment. And the Housing First approach is working. HUD has told us that we do have to prioritize those most in need. And once they started doing that, we've seen a drastic reduction in chronic homelessness from 2009, from 258 down to 24 in 2017. And right now, I'm extremely proud that due to the hard work of the street outreach teams and our permanent supportive housing providers, as of today, there are 5 chronically homeless people in these 5 counties, and 3 are rejecting any kind of housing right now because of the severity of their needs. But they're given housing without any preconditions or barriers to entry, such as sobriety, or forcing people to go to treatment or serving participation requirements. And these programs are 85 to 90% successful. So you can't tell me that they don't work. And a lot of times, when you look at the data, these permanent supportive housing programs are more effective than transitional housing at a lower cost. So we can serve more people at a lower cost. And these are just some more statistics through the Housing First, is that the unsheltered population has gone down by using the Housing First and putting people directly into housing and removing those barriers to housing. We've also seen a reduction of the people with severe mental illness or substance abuse problems who are homeless because they're being housed. While homelessness is increasing, people with those very high needs is decreasing. The increase, we think, is due largely to the increase in the rental markets in Buffalo, which are just skyrocketing. But housing is healthcare. Housing is a social determinant of health. Poor living conditions caused by poverty and homelessness do affect someone's vulnerability to illness and disease. If you're unstably housed or if you're living on the streets in a shelter, you're not going to a primary care physician. You're not necessarily getting a flu shot. You're not going to the dentist. You're just not taking, they're just not high priority. If you don't know where you're going to live from day to day, like you're just not doing that kind of thinking. You're just trying to get through the day. when you're unstably housed or you're living out on the streets, you have to contend with you're more likely to come in contact with communicable diseases, infections, extreme weather conditions, malnutrition, stress. Half of the women entering shelters show symptoms of PTSD. That's the kind of stress that homelessness in unstable housing can cause. And that condition is usually linked to combat veterans. People who are homeless are at greater risk of poor health. And again, just those chronic diseases, diabetes, hypertension, poor mental health, again, the stress and substance abuse. And again, it's going back to that sobriety. If sobriety was a condition of housing, many of us would be evicted shortly after happy hour. We tend to hold other people at a higher standard than we hold ourselves. We have a tough day at work. We may go home and have a glass of beer, a glass of wine. Tough week, we go out to happy hour, go out with some friends. But somehow, at one time, we were expecting people who are facing such stress of living out on the streets or not knowing where they're going to stay tonight, that they had to be sober for some reason. The mortality rate is 3 to 4 times higher for those homeless than in the general population. Again, because they're not taking care of their health care. Instead of requiring people to be clean and sober, there is something called harm reduction. Rather than expecting everybody to be clean and sober, doesn't mean that you aren't working with people. Housing first is not housing only. People do get support services. But the harm reduction model, and these are just examples that I borrowed from Karen Carmen, who was one of the pioneers of the Housing First model here in Western New York. But if somebody's consuming a lot of alcohol during the day, you try and get them to reduce their alcohol intake, and you try and give them water. I've learned a lot from the outreach workers over the years. Trust me, I'm no genius when it comes to homelessness. But you know, Karen, she would bring a case of water to her clients, but she could also see whether they were drinking that water by seeing how many bottles were left in the case. Then you start just telling people what the effects are of their drinking. But once people are housed, they don't seem to feel the need that you relieve that stress that may be coming with them. You know, there is some unruly behavior that comes with housing people with those extreme needs. These are more in the permanent supportive housing field and dealing with the chronically homeless. And it's not easy. Housing first is not a miracle. As again, I'm going to quote Karen, chronically homeless people are not puppies. It takes a lot of work. You have to make sure that they understand that they can be evicted. That if they start bringing a bunch of friends in their home, sometimes they can cause disruptions. I mean, everybody likes to have a party when you get a new apartment, but you just got to be careful on what you do. Again, you talk about reducing the number of friends that visit, and you know they increase the number of home visits based upon the needs of their clients. But at times, you know, clients do have auditory hallucinations that affect neighbors, and you know, people do not feel comfortable around people who are talking to themselves or hear voices. There are hoarders. Again, this is not easy. If you don't believe in guardian angels, trust me, I see them every day, and they're doing street outreach. There are guardian angels here on this earth. They're absolutely wonderful, wonderful people, and they do this every day, checking up on their clients. But this is just one example of after someone is housed and the reduction in alcohol consumption. Again, it doesn't go down to zero, but the alcohol consumption, it varies based upon stress levels. Is the same thing that happens, well, at least to me. I don't know who else is listening, but like I said, if I have a tough day, I may go home and have a beer. And then people do become isolated, and sometimes you need a change of a case manager. And then on the bottom scale, there was a great improvement after somebody was housed, but then the hoarding started to increase. And the case managers use some very innovative techniques to deal with their clients. And again, the work that they do is just amazing. But we just have to keep reiterating that housing is part of the healthcare. Some of the Medicaid redesign was based upon some of the things that we learned in the homeless field. But the high proportion of complex health needs and co-occurring health and behavioral disorders increases the intensity, the scope of services needed when someone's homeless. Homelessness increases the likelihood of excessive ER use, inpatient treatment, crisis services. One report from the New England Journal of Medicine showed that the extra cost of housing someone who is experiencing homeless is like almost $2,500 for hospitalization. So there's an additional cost for not housing people that's being absorbed by the healthcare industry. And this statistic just blew me away when I first heard it. For the cost of housing, for the cost of 1 week in a hospital, we can house someone for 3 years. I just let that sink in for just a couple seconds. 3 years. And this isn't to say that once somebody becomes housed that they don't have medical needs. Sometimes those medical needs will increase early on because they've been ignored for so long. But once someone is hooked up with a health home and it starts receiving those regular treatments, the health needs do decrease. And at a meeting that I'll talk a little bit about later, someone from one of the hospitals mentioned that one person experienced homelessness had 110 ER visits through 9 months of this year. 100, and that, again, that blew me away. We always hear the stories of how people are going to the ER for their primary care, but 110 times in 9 months. And that's just, it's almost daily. But when you look at the numbers, because I did this after the meeting, 110 ER visits, and just for the sake of argument, you do $2,000 per visit. It's $220,000. The one-bedroom apartment at fair market rent of $660, we could house that person for almost 28 years. You don't have to be a mathematician to figure out that something needs to be done in order to correct this problem. And if we can house somebody for that long and reduce those ER visits by housing them, there's an obvious connection that's missing. But housing people is cost effective. We've gone from trying to play with people's hearts, and especially elected officials and government officials, and talking about dollars. Dollars is the universal language. In Seattle, they have, it's called a wet house. It's housing for chronic alcoholics who are homeless, but we're also high users of Medicaid. And they found that the program costs were almost $2,500 less per month than they were if that person stayed in a shelter. I actually toured this facility when I was on vacation in Seattle. You know, this is what I do on my vacation. I'm a real fun guy. I tour homeless facilities. But I walk in there at 8:30 in the morning while I'm waiting for the executive director to come, Bill Hobson, who was one of the pioneers of Housing First, who has since passed away. I'm waiting there, and someone comes in to the front office, and they gave him a beer at 8:30 in the morning. He signed for it, and they told you can come back at 11 o'clock and get another one. And in this facility, they don't buy the beer, they don't buy or supply the alcohol, but they help you manage it if you so choose. And it was really fascinating to see how people and they do it on their own. It's not 100% successfully, and they did say that their biggest problem were people that were binge drinking. So there are problems, but it's very, very innovative, but it helped reduce those costs. Basically, it's the cost of Medicaid. Costs of rural homelessness in Portland, Maine. They had a 50% reduction in the cost of mental health services over a 6-month period due to a 79% drop in the cost of psychiatric hospitalization. Again, connecting healthcare and housing. And from Los Angeles, 4 chronically homeless people, when they were housed, saved the city $80,000. The evidence is clear. We started trying to do a cost of homeless study here in Erie County in my early days here at the Homeless Alliance, but we stopped because it's almost become, this is a known fact. We felt we didn't have to prove it anymore. And your patient is our client. How do we merge them into one person? And I'm going to get into some innovative ideas that are being done here in Erie County, in Western New York, and some that are being done in New York State and around the country. But recently, as a result of some of the meetings and collaborations, I'm still going to call you the P2 Collaborative, sorry, but ECMC now has 2 people trained in our homeless management information services to help coordinate discharge with the homeless service providers and connect them with coordinated entry. This was a major leap. I can't thank the P2 Collaborative, again, I'm sorry, for helping to start this. Things are happening. The city mission has dedicated some beds to releases from the psychiatric unit from ECMC also. That's being done right here, right now. So there are some things already happening. In New York City, in 2013, they offered a 10-bed medical respite in an existing transitional housing program. This for short-term residential care, because this is a concern here in Erie County and Western New York for the hospitals and for the shelters, because sometimes you're seeing patients being discharged to a shelter and the shelter doesn't have the staff necessary to take care of their medical needs, but they're not sick enough to be in a hospital, and they're taking up a hospital bed for someone that needs to be in that bed. So there's a gap in services. So there's a respite in New York City to take care of these patients that are sort of in the middle. Then the staff helps them secure permanent housing before they're discharged. I don't have the exact costs of the savings right now, but the hospitals would know what it costs on an average per day for that hospital stay versus a cost in that transitional housing. And 2 different hospitals are paying this facility a per diem rate in order to house these clients on a temporary basis. It's just that middle ground, and this need has already been identified here in Erie County. We just have to take that next step. There's also a facility in Troy, New York, on almost the same model for respite care. Just 10 private rooms for homeless men and women released from the hospital with ongoing medical needs, but again, they aren't sick enough to remain in the hospital, but they don't have that person that can take care of them in a shelter. And there's staff on duty 24/7. Support services are offered for health and housing navigation, and the average stay is 3 to 4 weeks. I don't know what the cost for housing someone in a hospital would be for 3 or 4 weeks, but I can guarantee you this facility is doing it cheaper. And I'm on the New York State Interagency Council on Homelessness. In these two models, they don't call them healthcare facilities. They don't call them shelters. They really don't call them anything. So they kind of avoid any kind of regulations. Maybe I shouldn't say that publicly, but they aren't necessarily heavily regulated in order to probably save some costs. But it's something that the New York State Interagency Council has identified as a need, and there may be hopefully some funding in the future that can help facilitate this. I'll go through these last slides fairly quickly so we can ask some questions if people want. The stories are almost the same everywhere. You know, somebody living on the streets for 5 years, going to the ER 2 to 3 times a month. Once they're housed, those costs go down, and some of the hospitals are actually investing in housing in order to help reduce their hospital costs. We just need to find the right person in the healthcare industry to pick up this ball and join with us, because the governor has put aside an unprecedented amount of money for permanent supportive housing and affordable housing. It's like $10 billion over the next 5 years 15 years, and to create over 100,000 units of affordable housing. There's tax breaks and there's funding available to accomplish this. I'm trying to plant some seeds here too. Right here in Buffalo, New York, UB Heals works with the outreach teams to, these are students from the UB Medical School, go out on the streets and do some limited triage, because they can't prescribe medicine, but they help engage homeless clients, and they do some basic medical services right there on the streets and try and link them with housing and medical services. That's happening right here in Buffalo, and this is just amazing. I know there have been several articles written regarding this. Again, in Connecticut, just programs that are being developed by the high use of emergency rooms and the high cost of people just unable to deal with behavioral issues. Again, we've got that dialogue going with ECMC. And if you can get that dialogue going, they've created patient navigators to help work with them to implement housing plans. We've connected people with the outreach teams to help connect people with housing. Erie County Department of Mental Health has been a great partner. Again, respite care in Boston. Just providing medical respite for people in homeless clients who are too sick for shelters but not sick enough to be in a hospital. It's happening. We just need to figure out how to get this happening here in Western New York. If you're interested in continuing this dialogue, a committee has been formed with the Homeless Alliance in conjunction with the West New York Coalition for the Homeless. And that meeting, I know it's very short notice, it's actually happening today at 2:30 at Cornerstone Manor at 150 East North Street, which is right on the edges of the medical corridor. And we started these discussions through the workshops that the P2 Collaborative has started. This committee was formed. We had our first one last month, and that led to the 2 people from ECMC being trained in HMIS. And we're literally in the baby steps of starting this collaboration. So everyone is welcome. Again, that's today at 2:30 at 150 East North Street. And if you need to contact me or need some further information, or you can't make it today but want to be invited in the future, you can contact me. This is our phone number, my email address. Our website has a bunch of information regarding our statistics, the grant that we write. people tell me that I sound really needy when I ask you to like us on Facebook. You know, we really, really want you to like us, because we do try and keep people updated on what's going on throughout Erie County and Western New York, and you know, some articles from what's going on around the nation. We're on Twitter at Hawny716, and that's the end of the presentation. Thank you for accommodating me.
Thank you so much, Dale. That was a wonderful presentation, lots of information to take in. So does anybody have any questions for Dale? If you do, please put them into the chat box. We'll give it a couple of minutes and see if anything comes up, and then we will field those questions to Dale, please.
I know I threw a lot of information out there in a very short period of time.
Just going back to somebody, Kimberly B. made a comment when you were talking about the respite care. She stated that we need that here as soon as possible. So while that's not a question, I just wanted to share that comment with you. And I agree.
Kim is, if it's the same Kim I'm thinking of, she's a registered nurse that you saw in the picture with UV Heals that that does street outreach through the Mad Urban Hope Center. And again, there's no doubt that there's a need, because I think if there are any hospital discharge planners on the phone, they know the need is there, that they simply don't know what to do with people sometimes. And they may get discharged to a shelter, and the shelter send them right back because they don't know what to do with them either. And that's not good for the hospitals, that's not good for the shelters, not good for the patient. There's no doubt that there's a need.
So we did have a question about the slides being sent out. We will send out the slides, and this webinar is also being recorded, and it will be posted onto our website, so everyone will have access to that.
I changed one or two slides, so I'll send you the updated one. I didn't change it by much, but I think I added two slides with the meeting today.
No problem. And Dale, we forgive you for calling us P2. It's okay.
I figured it's safer than calling you P2 than PHIP with population health, something or other, you know? So.
I think it's going to take a little while for folks to get used to not saying P2. P2 just tends to roll off the tongue, and PHC is, it's okay, but P2 is a little better. Well, I'm not saying,
take a while.
For us too, I think. So I'm not seeing any other questions coming through, so I'll just give one last second or minute for anyone to put in a few questions if they have anything. Okay, well, I'm not seeing anything coming through, so thank you all again very, very much for attending today's webinar. And again, a very special thank you to Dale for presenting today. It was a lot of information, a lot of wonderful, very useful information. So I highly encourage folks to, if you cannot attend the meeting today, because it is such short notice, please contact Dale. And if you're interested in working on that task force, then please contact Dale and join on board with that, because I foresee wonderful things happening with that group. It's a very passionate, dynamic group of people that are going to move this issue forward. So thank you, Dale, again.
Thank you, Karen.
And we'll be talking to you soon. And everyone, please have a great rest of your week, and happy Thanksgiving, everyone.